Matt DeCamp, who's the wise one giving me advice on how to move forward, is an assistant professor at Johns Hopkins Berman Institute of Bioethics and also within the Division of General Internal Medicine. He is a practicing internist who's just come from his national conference to join us here today. And he's done some very interesting research. Some of it at the moment is focusing on ethical issues in health reform and looking at how we engage patients in our decision making and developing priorities and programs. But his other areas of interest around how we prepare ourselves for short-term global health training. So I think he's going to draw on both of those experiences as he speaks today.
Yeah, there we go. That looks very familiar. All right, good morning. Thanks everybody for having me by. Much appreciated, and thank you, Carol, for your great thoughts, which I'm going to build on here as well. So, I'm at Dalhousie University. I'm in International Development Studies, so I'm not a clinician by any means, but I do study global health, and I've been on this beat for a few years. The class that I teach at Dalhousie, the first question I ask students in global health is with this slide. And I ask them, what caused these scars? And the answers range quite wildly. If I was asked to you, what caused these scars? Do you have any suggestions, any ideas? You're looking at scarring tissue, deep fibrosis tissue, likely from some sort of injury. Some people say a knife. Some people say a whip, right? The thing is that a knife or a whip, while they can cause these scars, they're relatively harmless as long as they're not in someone's hand. And they're also relatively rare to occur in places like Toronto. But if you're an artisanal rare earth miner in the DRC, this could be a very common injury to occur. What about this one here? What's causing the severe eye irritation? Is it because of a foreign irritant in the eye? Is it because the police are being a little harsh? Is it because your politics don't align with the local movement? So what's actually causing the severe eye irritation? And exactly here, what is going to cause the concussion? Is it the stick? Is it the police officer? Or is it being a Bangladeshi textile worker out protesting to try to get better working conditions and bathroom breaks? At what point do we actually see illness and injury, and at what point do we actually look at what health is all about? So this is what I want to talk about. What is health? I still get confused on what health is. The global health landscape, a few words on that. Back to the social determinants approach and how this could fit into a 21st century global health framework. Because I argue that how we are right now in 2016 when we approach global health, we still have some hangovers from the 19th century that we got to figure out and get rid of. So the point is, we don't really pursue global health as much as we do global illness. And there are serious ethical shortcomings to this approach, and it's worth exploring these new frameworks, and we can discuss. So right to it, definitions of health, right? We've had Carol's definition, but if you look through medical textbooks, biology textbooks, you'll see various definitions of health. The overall condition of an organism at a given time, soundness, especially body and mind, freedom from disease and abnormality, the level of functional metabolic efficiency of a living being, the state of being free from illness or injury, the state of complete mental and social well-being, right? They differ. Anything you notice in particular about definitions 2 and 4? Something stand out about that? Yeah, I mean, if you've taken time to study, lexicography and you're a dictionary writer, it's very rare that you would define something as important in this way. For those who have their Apples and their laptops open right now, I invite you to look at the dictionary function on your PC, on your Apple, and it will likely define health as being free from illness or injury. It's very odd in a common vernacular to define something for which it is not. Because if you also look in the dictionary under what is an apple, as in the fruit, it does not say it is not an orange. And yet this is one of the most common approaches to health that we have both in popular and scientific knowledge. There's a real risk to this when we actually don't focus on what health is about, because we begin to lose sight of how we obtain it. And as Shauna mentioned earlier, I'm a geographer, so I have a trade union obligation to put up a map. There's my map. And for those of you who know, maps can be distorted, they can change, they can tell different stories. So this is the Peters projection of the map, which quite rightly shows countries like Sudan being relatively large and countries like England being small geographically. We can just change maps, we can distort maps, we can tell stories with maps. So if we change the territory size to the proportion of the global population, things change. There's a lot more people in Europe than there is geography, so it swells up. Canada shrinks down, India's bursting, Japan's bursting at the seams, New Zealand's gone. 4 million people and 40 million sheep, nothing you can do about that. But we can tell stories with maps, and sometimes in global health, we focus a little too much on that relationship between place and illness. The territory size of the proportion of vaccine-preventable deaths. We see quite clearly that there's an overwhelming impact in the African continent, India, while the Western Hemisphere kind of disappears. We can do this game all day. We can look at the proportional amount of infant mortality deaths and how there's a disproportionate burden in certain parts of the globe than others. We can look at the proportional amount of deaths from preventable causes. And we start to see in this lens that there's some sort of inherent condition, an association between place and illness, even though there is no biological reason whatsoever why life expectancy in countries like Haiti should be 20 years shorter than that of Canada. There's no biological explanation why maternal mortality is alarmingly high in Afghanistan than, say, it is in Europe. These are social and environmental and political factors that govern this. It's no more right to say that there's a determination here between place and illness than say with this factor here. There's nothing biological that tells us that the amount of doctors per each territory should be overwhelmingly high in Europe and almost vacant in Africa, right? There's more to it. Part of it is how we approach looking at health and public health, right? Even here in Canada, we think a lot of our public health outreach and advocacy is about behavioral change. What are your habits? What are you doing? Smoking, drinking, playing with guns. We focus only on the absence of health. We lose sight of what actually creates and sustains health, right? Smoking and cigarette ads, right? The idea here was to try to encourage behavioral change of smokers in this country by using graphic images and harrowing stories. The campaigns continue on, and every country has its own unique approach to it. But the focus is often entirely on behavioral change, that you, the individual, will be able to give up smoking, even though we have very, very compelling data to show that if you are poor and marginalized, you are probably a smoker, right? People of the lowest income brackets in this country are likely to be the most frequent smokers. Those who have higher incomes have the ability to more support and resources to remove themselves from it. And yet none of our public health advertisement really looks at the social inequities here, or the class structure, or the income variance. That doesn't get brought up on our public ads if you just explore what you see around our urban landscape. Social determinants of health, the conditions which people are born, grow, live, work, and age, including the health system shaped by the distribution of money, power, and resources at a global level, they're all governed by policy. And policy is governed by people's ability to change and engage government. Some of the most extreme cases, like here in Brazil, right? You see a phenomenal difference in what the social determinants of health would be on the left side of the fence to that of the right side of the fence, right? Same place, same location, same demographic, same language, but a phenomenally different package of health challenges on one side of the fence over the other. And how willing we are to discuss that is shockingly little. One of the things that we've noticed, and again, this draws a lot on Cochrane's work and a bit on Wilkinson's work as well, is that we see at times when societies do address class structure, not just economics, not income difference, but actual class and hierarchy, we see general health outcomes improving. For example, in World War II in Britain, phenomenal bit of data to show that life expectancy actually increased during World War II. That didn't make any sense, right? London is being bombed, people are going off to fight on the front lines, but yet life expectancy went up. Part of the reason for that was that, yes, people were having to hide and tunnel in the underground tube stations, but there was almost full employment. People had better access to proper housing, food, healthcare that didn't exist when we're back here in the Downton Abbey class structures of the 1930s and the 1920s. right? But after that, before even the establishment of the NHS, you saw a very dramatic increase in benefit in most of the health determinants of the UK at that time. The Queen, Princess Elizabeth at the time, sure, she wasn't in the palace, she was a truck mechanic, right? The point is that people at the top came down a little bit, people at the bottom came up a little bit, and that closing of the gap in those class structures actually created massive health benefits to the population, right? And this is where it sees and begs us to look further at the general social, economic, and cultural environmental conditions in which we live, work, and grow, and how we shape and structure our communities. Societies that actually are changing the structure of that blue belt often come along with very interesting health outcomes. The problem is that we focus so much on illness in global health, and we tend to ignore more generally within our own health systems the importance of that class and structural inequity, that some very complicated diseases, cancers for example, really go unnoticed in global health. I also asked my students in the class of about 70, we do a show of hands, I ask anyone, do you know anyone who's faced guinea worm disease? And this is Halifax, Nova Scotia, so, few hands go up in the air, they're like, what's it called, dracunculiosis? Close, Does anybody know anyone who's suffered from polio? You might see one or two hands go up. Anyone know someone who's suffered from tuberculosis, right? More hands go in the air. What about someone who's suffered from HIV? And I mean, to personally know them, you can look in their eyes and say, I know your story, right? But then we do this last one. Does anybody know anyone who suffered from cancer? Every hand is in the air, and with it come very personal and painful stories, right? And we ask the question, why is that? It's a bit of an elephant in the room, isn't it now? Because we lose 20,821 people from cancers every single day. We ask the students, and we refer to the literature, and they say, well, there's a lot to say that more developed, more advanced societies that have gone through an epidemiological transition will likely have higher rates of cancer. Right? We look here at this graph here, breast cancer, new cases per 100,000, income per capita. The yellow, the orange countries are of higher income. You see the blue countries, African nations, light blue, South Asia, with lower rates, right? So we buy into this. If you go to, say, to California, if you go to a Starbucks, you'll see Prop 65 that will warn you that there's a lot of ingredients at Starbucks that could be carcinogenic. It doesn't stop anybody. We're lining up out the door and people are missing their planes. But we get this impression that somehow cancers are just entitled to those of affluence. So much so that this character here, he said in 1991, in a memo as head of the World Bank, he said, a given amount of health-impairing pollution should be done in a country with the lowest cost. I think the economic logic behind dumping a load of toxic waste in the lowest wage country is impeccable. He goes on to say countries in Africa are vastly underpolluted, working for the World Bank in 1991. And he says the concern over an agent that causes a 1 in a million change in the odds of prostate cancer is obviously going to be much higher in a country where people survive to get prostate cancer than in a country where under 5 mortality is 200 per thousand. Who was that? That was Larry Summers, Chief Economist of the World Bank, Secretary to the Treasury, President of Harvard, and Director of the White House Economic Council. Now, that might seem, and rightly so, quite offensive, this famous Summers memo from 1991. But if you look at this graph in itself, you think, well, maybe it makes sense. But this is the cases per 100,000. This is not the mortality rate. And when we actually look at what the mortality rate is of just breast cancer, the United States, up there at the top, is no longer at the top. The Philippines is now in first place. And you look at this graph, and there is no economic association whatsoever, geography, income, or anything else, to show that the prevalence of mortality of breast cancer is different from the US to countries in sub-Saharan Africa. You do it again this way. Cervical cancer, new cases. Here, you see Haiti is at the top. Right? Poorer countries are having a higher rate of this. African countries here, you look at the mortality, it's still up there. It's still disproportionately affecting poor countries. Here, prostate cancer. Again, detection rates in the US are very good at this. What about mortality rates? Help? Thank you. Barbados, right? The graphs change dramatically. Between detection and mortality, that economic association is absolutely eliminated. Even though there's a lot of evidence, there's research out there to show, well, what sort of carcinogens are people being exposed to in low-income countries. Some work in Rwanda points out that, yes, just on tea leaves, these culprits, right, and tea workers who are there being exposed to the pesticides, is this why there's higher rates of detection of cancer in Rwanda, for example? Why is this? So where do we go when we deal with this? If we can argue for a minute that the burden of cancer in poor countries is that, in a similar fashion to that of resource-flush countries, where do we actually give our money to global health? Numbers here from the United States. 2009, the US government, through USAID, I mean, this is state level, this is not NGOs or charities. HIV/AIDS received $7.7 billion in 2009, PEPFAR and others. Tuberculosis received $4.4 billion in 2012 from the US government. Polio received $1.1 billion in 2010. Guinea worm disease received $32 million in 2011. Cancer received not even $1 million for oncology care on the African continent, 53 countries. How are we doing? If you search through Global Affairs Canada, the research base for projects, just basic search, you look at the projects we have going right now in HIV, 33. Switch it over to tuberculosis. We have 8 projects. Some are closed, some are terminating, but we're doing something. Polio has been something that Canada's been very active on, so there's another 8 projects there that GAC is funding. And we turn the search criteria over to cancer, Africa. What are we doing? Nothing. Absolutely nothing. It's not on the radar. It's not interesting enough to get funding from Global Affairs Canada. The numbers: 2/3 of new cancer cases occur in poor countries, 70% of cancer deaths occur in poor countries, 13 million cases a year, 7.6 million deaths. And again, the burden on this is in poor countries. It's also shocking that when you look at some data historically in the US and Canada, we've made incredible gains on heart disease, cardiovascular disease, influenza. Cancer hasn't budged since 1950 to 2001. Another graph that shows the same thing. And maybe because it hasn't budged, and maybe because we are still trying to wrestle with it here, we've yet to open that empathy to share these resources with other countries. Maybe it's because I'm, again, no oncologist. I leave it to those who know this more than I do. But do we really understand a cell's marching orders to the point where you have that loss of normal growth control, where it gets so bad that you have this mutated divide? Do we really understand what's going on there? Do we understand if it's a genetic defect? Do we understand our cancer's environmental responses? Do we really know? Is it both? We're not sure. Right? We have good ideas, but it's not conclusive. A 100-year-old woman says drinking cigarettes keep her young, right? I mean, we get stories like this all the time that just continues to baffle the public imagination. Lots of usual suspects. We know that cigarettes are bad for us. We know there's strange things in our soft drinks that may not be helpful. We should try to avoid sunburns, right? But what about environmental pollution? Is that something that we can change with behavioral change? Does that require some sort of advocacy? Growth hormones that are found in milk, right? The RGBH debate in the United States and why it's banned in Canada and Europe but not in the US. How about exposure to toxic materials like asbestos, right? We know all these things factor into it, but at what point do people not have control or the ability to get away from that? And at what point do these environmental and social problems impact a cell's marching orders? We see that the advocacy and the fundraising for cancer in the past few years has changed dramatically. Right? The pink ribbons, we know there's a lot of money that gets brought into it. We know it does a really great job for awareness. But we've also seen a very demilitarized approach to cancer activism. Right? We've seen that there was more advocacy in the 1980s to actually address industry and workplace conditions. And it's really transformed into messages of destigmatizing and hope. Right? Deserts with ribbons, White Houses with ribbons, yogurt lids, personal care products, pink toasters, pink beer pong tables, pink buckets, and of course, the pink handgun. right? It's a very different approach to what we've seen in terms of approaching cancer. And the money that's raised, where does it go? Most of it's going to genetics, some of it's going to causal, some of it's going to treatment, but very little is going to prevention. And that's just by the money alone, and we understand the costs that go into cancer research, I get that. But in terms of the number of projects funded by the number of cancer research projects in the US in 2013, disproportionately low that we're looking at prevention, right? We're not paying attention to it here in this way, so how can we begin to understand approaches to cancer and global health elsewhere? The other assumption is that we assume that if you're going to approach cancer, you need the best technology. You need machines. You need access. You need insurance. You need to make sure that drugs are affordable. But when you have surgery wards that look like this, where do you begin? Right? Where do you begin? It doesn't even fit into best practices. You couple that with drug companies that are saying, you know what, we're not making drugs for the poor. These are for Western patients who can afford it. And we have some pretty big ethical conundrums, right? When the governance of a health system like here in Kenya, this is not a circuit board, this is how donor structures fund health services in Kenya, cancer just isn't on there because no one's bothered to go for that. Is it complicated? Are we too worried about it here? I don't know. But what I can leave you with is the anecdote that there are some countries that are putting oncology into their global health outreach, Cuba being one, right? The oncology wards are basic. They're there. They're available and they're free for Cubans, but they're also available and free for those who come from other countries, right? Venezuela, Honduras, Haiti. Patients who have cancer can come to Cuba for free care, right? Something they started back after Chernobyl when they were bringing in children who were impacted by the Chernobyl crisis, right? For years, they came to Cuba to get free health care. And it's something that we're seeing more and more medical brigades that Cuba engages with here in the Ebola crisis, not just approaching Ebola as the issue for going in, right? But going in and also providing primary care, trying to look at systems building, capacity building, trying to go in and not just look at an illness, but to look at broader issues that impact health. So when you have Cuban medical brigades that offer their services to Katrina in 2005, the US government says no. The same medical brigades go overseas, 187 strong there, off to Guatemala and then Pakistan to provide work there. And then when they leave, they offer scholarships to students, right, here at the Latin American School of Medicine. They also provide other levels of care and cooperation. So all this to say is that there are other models that actually have approached this problem. But when it comes to cancer today, the points we can leave you on, is it really a past oncology for contemporary patients, as Livingston has pointed out? What about the lack of morphine in Africa? The ability to get painkillers is almost impossible in some countries, right? And why does geography matter? Have we ignored cancer so much in Africa that it's actually a new collection of diseases that we just don't have the best practices for anymore? Martin Luther King said it, of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. And I think that we can see that when we have such an inability to deal with things like oncology, we're there. Because even then, we're still not sure where these scars started from. So all that to say is that despite the class inequities that exist on a global scale or on a local scale, it doesn't mean that we should abandon our moral commitment for those on the left side of the street, just because we're focused on those on the right side of the street. It's difficult, but it's something I think we should have a conversation about today and in the future. Thanks.